Greetings everyone, Assalamu alaikum. I am Yazan Mazen, a medical intern in Dubai Health, and I'm a graduate from the University of Sharjah College of Medicine. Today we're going to talk about nephrotic syndrome, one of the glomerular diseases, inshallah. So, to start with, nephrotic syndrome refers to a group of disorders characterized by massive proteinuria. By massive, we mean a lot of protein is exiting the body through the urine. It's more than 3.5 grams in 24 hours. This is the definition. And the reason why this happens is because there's damage to the glomerular filtration barrier. We're going to talk about that now. And possible causes could be idiopathic, so there's no reason, there's no underlying cause at all, or secondary to systemic diseases. We're going to talk also about them. Some diseases that can cause nephrotic syndrome as well as toxins. And if it was unmanaged, it can lead to chronic kidney disease. And if it was not managed also as well, it can lead to end-stage renal disease, ESRD, which means that the patient may require dialysis. So what would make the glomerular filtration barrier are three parts. One of them highlighted is the endothelial cell. This is the line of the capillary. We have the glomerular basement membrane, highlighted in yellow. Then we have the podocytes. So damage to any of them can lead to nephrotic syndrome. This will lead to also leakage of the protein, leakage of proteins into the urine. And we know proteins are large molecules, so there could be significant damage so that they can leave. We're going to discuss another video about nephrotic syndrome, the other type of glomerular disease. In nephrotic syndrome, there will be inflammation, glomerular inflammation, which lead to damage, which will lead to also leakage of red blood cells, so this will lead to hematuria. But here we have proteinuria, and disruption of this barrier can actually make the charges affected, so there will be imbalance of the charges, and this will lead to protein exiting because protein have certain charges around them, and here there will be also certain charges that will not allow protein to exit. But because this is disrupted, the charges are disrupted and are imbalanced, so this will lead to leakage of protein. We have some normal histologies so that we are familiar with them before we see the histology of each disease. We have the white space around the glomerulus. This is the glomerulus. This is the Bowman space, and we can see there are many cells present in the glomerulus. We have the messenger cells with the capillary lumen, which will include the RBCs. We also have the podocytes that we discussed earlier. We have also the basement membrane, and here another picture which has more details, more labelings, annotations. The white surrounding would be the Bowman's space, and you can see this is in the periphery are the podocytes. So the ones that are closer to the Bowman space would be the podocytes because there's the one close to it. And we have also the blood cells, mesangial cells, the endothelium. The take-home message just to familiarize yourself with how it normally looks clear, and also there are many cells present. We're going to see the pathologies. You may find, like, for instance, one area would have a lesion where it will look thickened or have sclerosis. We may see also, for instance, that sometimes all the glomerulus will be affected, sometimes part of it, sometimes will be thickening in one part. So just to be familiarized with the normal, so we can see the abnormal and know that this is the lesion, this is the most likely disease. Genetic characteristics of nephrotic syndrome, this is a common feature for all of them, is that there is increased urinary protein loss, so lots of protein are lost, so there will be proteinuria, and not as minimum proteinuria, which is massive, so we find 3 plus or 4 plus on urine dipstick, because sometimes if there was diabetes patient with microalbuminuria, there could be like 1 plus or 2 plus or trace of protein, but here no, there's 3 plus or 4 plus, so it's large amounts. And as we said, the definition is more than 3.5 grams in 24 hours. And one of the proteins in the body which are important protein is albumin. Albumin will be lost in the urine, so this will lead to hypoalbuminemia. There will be low albumin in the blood, and this will lead to low osmotic or oncotic pressure in the blood, and this will lead to fluid leaking into the tissues rather than staying in the vasculature. This will lead to edema. It could be peripheral, so there will be leg swelling, or it could be also periorbital around the eyes, as is present in the picture here. Periorbital swelling in this child's face. This also increases of hypercoagulable state. Why? Because antithrombin 3 is lost, and we know that antithrombin 3 reduces the risk of coagulation. But if this is lost, then there's nothing that will stop the coagulation from not happening. So there's an increased chance of it happening. And we also have increased risk of infections due to loss of immunoglobulins in the urine because they're also proteins. The patient may also tell you in the history that there's also frothy urine, so it looks foamy. And when you do urinalysis of the urine, you may also find fatty casts. This is a characteristic of nephrotic syndrome. For nephrotic, it's actually different. It's going to be red blood cell casts. So fatty casts would be for nephrotic, red blood cell casts for nephritic. And another point that's present also in nephrotic is hyperlipidemia. So this sometimes I find that it could be present. Here are another set of pictures showing the edema. There's a pitting edema or the lower limb edema of the lower limbs here. And also here perioptic edema around the eyes of these patients. Management in general, it is generally disease specific, so it depends on the disease, but these are common management lines. We're going to see for nephritic it's actually different because it depends on the disease. But here for nephrotic, they have similar lines of management. One of them would be use of immunosuppressants, and steroids are commonly used agents, especially in some diseases. They are excellent drugs. They help to manage disease and provide very good prognosis. Sometimes if steroids are not responding very well, patients aren't responding very well to steroids, when you use other immunosuppressants such as cyclophosphamide, calcineurin inhibitors. But just remember steroids. This is the key drug you should remember. Many diseases are started with steroids. If it doesn't work, then we use other agents. I also ask the patient to reduce their salt intake or sodium so that we can also manage the edema as well as the fluid restriction. We also sometimes use the angiotensin converting enzyme inhibitors, ACE inhibitors, or ARBs, angiotensin receptor blocker, if there's proteinuria, and so sometimes we may use it because they have nephroprotective effect. They protect the kidney. So we know that the progression of nephrotic can lead to chronic kidney disease, which lead to end-stage disease, which requires dialysis. So in order to prevent that, we may ask the patient to take ACE inhibitors or ARBs in order to measure proteinuria and also to protect the kidneys. If the patient had hyperlipidemia, we may consider lipid-lowering agents such as statins. If the patient had increased risk of coagulation, we may consider thromboprophylaxis. For the infection, we may consider, for instance, vaccination, immunoglobulin. The take-home message for the last 3 points is just to know that these are also part of the problem for nephrotic syndrome, so don't forget about them. And of course, we should always consult the experts in this field. So the nephrologists know a lot about the disease, so they also consult when there is nephrotic syndrome, especially for these 3 parts. We may consider managing them because they are also part of the problem list. But the most important, remember, we use steroids and salt restriction, fluid restriction. We also use ACE inhibitors or ARBs for proteinuria. This is again in general. This is how we classify nephrotic syndrome. We have these 2 diseases under podocytopathies, and we want to know why they're called like that. Immune complex deposits and membranous and membranoproliferative. We also mention a special feature of membranoproliferative glomerulonephritis, and there are also other substances deposits or systemic disease. These 2 are some of the systemic diseases that can lead to nephrotic syndrome. So we're going to talk about all of these in this video, inshallah. First one is minimal change disease. It's also known as lipoid nephrosis. This is our name for it. It is the most common cause of nephrotic syndrome in children. So if you have a patient with nephrotic syndrome in a child or pediatric patient, think of minimal change disease. Usually it's idiopathic. Sometimes you may find the history that the patient had a recent viral infection such as an upper respiratory tract infection, URTI, and then patient developed nephrotic syndrome, which is most likely minimal change disease. So this sometimes you can find in the history, and of course you can ask about if there's any recurrent infection, if there's also frothy urine or foamy urine. It has them also in history, as we discussed previously about the common features. The good thing about this disease is that it has excellent response to steroids. We can see the other disease, which is similar to minimal change disease, doesn't respond very well to steroids, unfortunately, so we use other drugs also. But here, there's excellent response to steroids. For the imaging studies, we meant here that we should use the microscopy. We have 3 types that we use in many nephrotic and nephritic syndrome diseases. The light microscopy, immunofluorescent microscopy, and electron microscopy. For minimal change disease, just remember that we use electron microscopy because this is the one which will show the disease, which is the feature, which is the loss of effacement. There's effacement of podocyte food processes. The rest, which means the light and immunofluorescent, are likely to be normal. So look for effacement of podocyte food processes on electron microscopy. This is the take-home message. This will be also the buzzword that you're looking for in exams, in board exams, and also university exams, or in exam in general, and OSCEs also. So this would be the normal. This is the electron of a normal finding. This is the abnormal. Here's also image that will explain it in a simple way. We have here the capillary. This is the endothelium in yellow. We have the gray lining, which is the glomerular basement membrane. The green is the podocyte. These are the food processes. Here you can see them. They're like projections, and they're also delineated by arrows. Here there are lots of food processes, and as you can see, it's flat rather than having these projections. It's actually flat, and this is the underlying cause of minimal change disease. The next one is focal segmental glomerulosclerosis. This is like the brother of MCD, and think of it as MCD but in adults. And similar to MCD, we can expect immediately that for electron microscopy we will also have the same finding, a patient podocyte food processes, just because we know that it is similar to MCD. In terms of etiologies, it can be idiopathic, since we don't know the cause, or it could be secondary to other conditions, and the associated conditions are a lot. But what do we look for when it comes to like board exams and also university exams that sometimes may hint towards focal segmental glomerulosclerosis? Look for HIV infection in the patient, or think of it as the next step that you want to check if the patient has this infection. Check for sickle cell disease, if the patient had any recent or use of heroin or interferon treatments, such as for hepatitis B, hepatitis C. For light microscopy, you may find the features from its name, focal segmental glomerulosclerosis. So you may find that there is sclerosis of a part of the glomeruli, and you find also hyalinosis. So there's like pinkish color of it. The first would be negative, and as we mentioned earlier, later microscopy look for podocyte food process effacement. Now here's the picture that we have. You also can read the caption here if you want to know what they're talking about. Here's also the source. We have two glomeruli here. On the left side, this is the normal, and the right side where we have the lesion. You can see that on the left side, all of the glomeruli looks the same. There's no, like, for instance, one side which has different features than the other. So like not like, for instance, one side has more pinkish color, or like, for instance, less nuclei, or for instance, thickening or clear lesion over the other. But on the right side, we can see that this part here, just click here, yes. So the one encircled in the yellow circle is the lesion. You can see it's different than the others. This is actually the thickening. This is the sclerosis, glomerulosclerosis, and the name of focal segmental glomerulosclerosis gives you also a hint and has meaning. These terms are used because they have meaning. Focal means that less than 50% of the glomeruli are involved, versus diffuse. Diffuse means that's more than 50%. We're going to see that some diseases, when we go over nephrotic syndrome, inshallah, that there will be many diseases which have the name diffuse. Diffuse means more than 50% of the glomeruli being involved. Here it's focal, so less than 50. Here we only have two glomeruli, but when we have a bigger picture, we can count, like, for instance, how many glomeruli are involved. We can define that it's less than 50%. Segmental means part of the glomeruli is involved. Like here, it's only a part of this glomerulus, not like all of it. And here, if you want to see the definition, segmental, it's only a segment or part is affected. Focal means that less than 50% of the glomeruli are involved, unlike diffuse would be more than 50%. And then also, if you want to see the effacement of the podocyte food processes, here's the controls. It is normal. You can see here some of the projections. Previous picture was much clearer, but here you can also refer, and also here you can see the projections of the podocyte. Here it's lost, it's flat, similar to minimal change disease. Unfortunately, in focal segmental glomerulosclerosis, they're responding poorly to steroids, and sometimes we have to use other drugs, like cyclophosphamide. We also have to use, more like we're going to use ACE inhibitors and ARBs to protect the kidney, and there's also proteinuria to delay also the progression to chronic kidney disease and delay progression to end-stage renal disease requiring dialysis. Diabetic nephropathy. Now we're starting with the systemic diseases. We've talked about the podocytopathies, which involve the podocytes. Diabetic nephropathy, from its name, we're going to think of patients with diabetes, and the underlying cause here is that it's caused by non-enzymatic glycosylation of the basement membrane. So there'll be attachment of glucose to the basement membrane without the need of enzymes, because of the chronic condition, also having high levels of sugar in general, due to thickening basement membrane, and this will increase permeability, and this will cause the nephrotic syndrome, also allowing the protein to enter the Bowman space and also zinc in the urine. In light microscopy, we have to look for, think of the glomerular basement membrane because it's the cause. There's thickening. This will lead to increased permeability. Here you can see that the lining here is thick. Also here, terribly thicker. And also a classical feature present is the eosinophilic nodular glomerulosclerosis. They have a special name, so look for this in your board exams. Kimmel-Steele-Wilson nodules. This one is denoted here. Okay, this can be useful for board exams because they may mention it. And the other picture, this is the Kimmel-Steele node that we talked about. And you can see also here that this is the thickening. I'm not sure very clear here, but this is something that you have to look for in the exam, as if it's on multiple choice or it was in the OSCE. And make sure to mention this, there will be thickening of the basement membrane, and also there will be the glomerular thickening, and also the Kimmel-Steele nodules, Kimmel-Steele-Wilson nodules. Amyloid nephropathy, think of it as, or remember that it's present commonly in the elderly. So if you have an elderly with nephrotic syndrome, think of amyloid. And we have two types. Look for AL and AA amyloidosis. AL amyloidosis, think of present in multiple myeloma. So if an elderly with multiple myeloma develops nephrotic syndrome, think of AL amyloidosis. This is the subtype. Note for your exams, as sometimes they may require you to know the type. For AA amyloidosis, think of autoimmune or chronic disease such as TB, rheumatoid arthritis. And microscopy, just remember amyloid in general, not just for nephrotic syndrome for this video, but inshallah in the future. So if you see it, for instance, in medullary thyroid cancer, it also has amyloid. Or if you have an amyloid in the future, if you have it, just remember congruent stain. If they mentioned the exam or you're discussing about it, think of amyloid. And also it will lead to apple green birefringence on the polarized light. So this is three things remember for amyloid. So when there's amyloid mentioned, remember congruent stain. Remember also apple green birefringence. This will help you inshallah when you do multiple choice exams, and also when you discuss with a colleague, or also in the OSCE or VIVA. Immunofluorescent, positive also for the AA protein and AA amyloidosis, or for kappa and lambda light chains and AL amyloidosis. Electron microscopy, you may find amyloid fibrils. So this is take home message for amyloidosis. Remember it's present in the elderly, and look for the conditions which could be governed malignancy such as multiple myeloma, or chronic conditions such as arthritis, TB, and remember congruent stain. Remember also the apple green birefringence. Now we're going to talk about the immune complexes. We have the membranous nephropathy, and membranous nephropathy is also known as membranous glomerulonephritis (MGN), and the causes here similar to focal segmented, it could be like primary or secondary. Primary here is associated with anti-PLA2R antibody. Just remember that this is associated with this antibody. Or secondary, it means there's an underlying cause, and also there's a long list actually. But just remember some of the key features, like we talked in focal segmental, we talked about HIV infection. Here we're talking about hepatitis B and hepatitis C. We also talked previously about sickle cell disease. Here we're looking for autoimmune conditions such as SLE. Solid tumors like cancers or drugs, also such as gall, are sometimes associated with membranous nephropathy. So look for these hints in the exams, because sometimes the papers in the case scenario, this can be like a good hint. For like microscopy, look for thickening of the glomerular capillaries and basement membrane. So the membrane here is involved in the name, like membranous, so it's going to be thickened and affected. And here, the most important feature you should look for in electron microscopy is granular subepithelial deposits. Subepithelial here is important because when we talk about membrane proliferative, it will be subendothelial, or it could be intermembranous. But here subepithelial is from subepithelial is from membranous. All right. So it can lead to this appearance of spike and dome appearance. We'll explain it shortly. So here's the image picture of the glomerulus and also the beginning of the nephron. So you can see here that the pink lining is the basement membrane. The purple here actually, this is the pink, which will be the glomeruli, or this will be capillary, sorry, and also be lined by the endothelium. So we have the endothelium, we have the purple lining, it's the basement membrane, we have the green arrows or spikes, these ones are the podocytes. All right. So again, these three would make what? They would make the filtration barrier, glomerular filtration barrier. So what happens here is that in membranous nephropathy, there will be deposits, immune complex deposition outside of the glomerular basement membrane, but below the podocytes. So it will be subepithelial. I have another picture here. So this is like a magnified view. We have the endothelial cell, basement membrane, epithelial cell. When there's the immune complexes here, it will be outside of the basement membrane, but below the podocytes. So it will be subepithelial. That's why it's called subepithelial. But when we see membrane proliferative, it will be subendothelial most likely, or intramembranous. Alright, so look for these keywords because it will be important for your exam. Subepithelial, subepithelial. Also, we'll see this in the Nephrotic syndrome, inshallah. And here also we can see that here there's the immune complex. You can see it's written here in blue, light blue. This will lead to the spike and dome appearance. You can see also the normal here. This is the endothelium, this is the basement membrane, this is the podocytes. Here we can see that there is the spike and dome appearance. Look for this also a keyword. And here if you want to also pause the slides, you can see the explanation. I found this simplified explanation. I found it also nice, mashallah. If you want to go over it, and also the link if you want to also see it as well. And also explains about what I mentioned previously about the site of the immune complex deposition, subepithelial, so it will be outside of the basement membrane, but below the epithelial cell or the podocyte. Okay, so it's the epithelium. Because remember, we have the endothelium, which is in the lining of the capillary. Then we have the basement membrane. Then we have the epithelium, which is also the podocyte. Okay, and if you also went to the previous slide, you will notice that there is also like visceral and parietal podocytes or epithelium. No need to go into these details, but just if you want to know more about it. Okay. The last slide will be about membrane proliferative glomerulonephritis. Just a brief mentioning. The most important thing is to remember that it can present as nephrotic syndrome or even sometimes mixed with nephrotic syndrome. So this disease is special. And also discuss about another disease, another set of diseases which can also manifest as nephrotic, or sometimes can present like either or. Okay, so this is important. One of them is membrane proliferative, and there are different types. There are many types. We'll discuss more about inshallah in the nephrotic syndrome video. But just know that for this disease, there's deposit of antibodies or complement factors in the mesangium. The mesangium here will be involved, and what will also be involved here is the glomerular membrane will be split. So look for this as the keyword or key phrase, the buzzword, double contour or tram-track appearance. We mentioned for membranous, it is the spike and dome appearance in the electron microscopy. Here, look for this tram-track appearance or double contour. And here the deposition would be subepithelial and intermembranous versus subepithelial, which is present in membrane glomerulonephritis. And this is again depends on type. This would be for type 1. This would be for type 2. Thank you for listening. And if you want to know more about nephrotic syndrome, there's another video for it that you can also watch under PACademia, inshallah. Thank you very much.